Good morning and good afternoon, everyone. My name is Sarah Hamilton. I am the Director of Operations at Funders Concerned About AIDS, and I'm so happy to welcome you to our final webinar of the year, Advancing a Cure for HIV, What is Needed. We're doing this today in partnership with AIDS Funds, and we're so glad to have all of you with us. I wanted to quickly go over logistics and let you know that today we'll be having French interpretation. So if you would like to listen to this discussion in French, you just choose the globe and select the language. Captions can also be enabled at the bottom of the screen. We really encourage, we know this is a webinar, so you can't ask questions directly, but we do encourage you to share your name and your pronouns and where you're dialing in from today in the chat to kind of encourage engagement and community building. You can use the chat and the Q&A function to ask questions throughout, and we will have a discussion portion at the end of the agenda. We ask that you not use any AI bots for note-taking today, just for security purposes. We also are recording today, so just keep that in mind. And also, as always, we remind you that this is a non-solicitation space. So in your chat and your Q&A functions, we just ask that you not make any direct asks of the funders that are on the call today. With that, I'm going to pass over to Mason Davis.
Thank you so much, Sarah, and thanks for all your work today making this happen. Good morning, good afternoon, good evening, everybody, wherever you are around the world. Mason Davis, the Executive Director of Funders Concerned About AIDS. I use he, him pronouns and absolutely delighted to welcome you today to a really special session just following World AIDS Day. We've got some spectacular speakers today on the call, as well as registrants from 19 countries around the world. And so we're really delighted to be able to connect with you. For those of you who may be new to FCAA, Funders Concerned About AIDS is a philanthropy-serving organization dedicated to mobilizing the resources needed to end the global HIV pandemic and to build the social, political, and economic commitments necessary to attain health and human rights for all. And I am delighted to welcome you on both behalf of FCAA and our partner AIDS Funds for this briefing on advancing a cure for HIV. Now today, this call, developed and convened in partnership with AIDS Funds, thanks to a lot of great work from Remco, who you'll hear from soon, is designed to explore how funders, researchers, communities, and other stakeholders can work together equitably in the interests of developing an HIV cure for all, hopefully as soon as possible. Now, we know it's been a really difficult year in the HIV landscape, and I would say in the world in general. A lot of really challenging news about the politicization of PEPFAR, threats against services, challenges for funding, and criminalization of a lot of impacted populations. So it's nice to end the year actually coming together to discuss something that gives us all hope, a cure. So today we have an exciting lineup that will help us talk through opportunities and challenges, and importantly, how this work, much like the HIV progress to date, can and must be done equitably and in partnership with community. So to begin, I am absolutely delighted to introduce you to my co-facilitator, Remco van Leeuwen, who will kick us off. Many thanks to Remco for making today possible and inspiring this session. Remco serves as a strategic advisor to AIDS Funds in the Netherlands, where he coordinates their program to find a cure for HIV, which brings the possibility to an end to the HIV epidemic in sight. And with that, I'd like to turn it over to Remco to get us started. Remco?
Thank you, Mason, and thank you for those kind words. Good morning, good afternoon, or good evening, everybody. It's nice to see so many people in this webinar from all places in the world. Like Mason mentioned, we have, so short for before the holidays, a story of hope, we think. Was thinking what to tell you as a kind of personal introduction and actually, what I would like to share in the next 30 seconds or so is that I started my career as a young researcher after finishing my medical schools in the early 90s. And those were the days that you were actually testing new antivirals on patients with HIV. At the time that having HIV was actually still a death sentence. And within the time period that I did my research and finished my PhD, so a big change from what the monotherapy with those antivirals to the combination of antivirals, which at the time we called highly effective antiviral therapy, made for the prognosis of patients. Which really made HIV and AIDS from a deadly disease into a chronic disease, which you could live for a normal lifespan. I have a feeling that we're at the same point in time with regards to finding a cure for HIV. And I hope that we can share some light on that feeling that I have with that stellar panel of speakers that we have today. We have organized this in 3 different sessions. So the first session will be on the scientific progress, the state of the art, where are we now. The second session will be on the funding aspect. So how does the funding landscape look like at the moment, and what will be needed to advance this further? And in the last panel, we will talk about community involvement and how we can get communities close to the design and the execution of HIV cure research. We have short presentations today. The discussion will be at the end. Mason and I will facilitate that, but we'll closely look at the chat and see what questions come in. So we have prepared some questions to the panel, but we would very much like to relay the questions that you have as an audience to the speakers as much as possible. So with that, I would like to open the first scientific panel, and the first speaker will be Professor Tumbi Nkungo from the African Health Research Institute in Durban. Tumbi has many positions, amongst which that were both part of the Scientific Advisory Board on HIV cure from the IAS. And Tumbi, much looking forward to your insights on the state of the art for HIV cure research. Floor is yours.
Thank you very much, Remco. As Remco mentioned, my name is Tumbi Nkungo. I'm going to be talking about the rationale and scientific approaches to HIV cure, particularly as it relates to low and middle income countries. So I think I'll start with the good news, which we are all aware of, which is that over the past 2 decades or so, the number of new HIV infections worldwide has been going down significantly, as shown by this data from UNAIDS. And this is because of the rollout of antiretroviral therapy. However, if one looks at this downward trend of new HIV infections, you can see that we missed the targets for 2020 for the number of new infections, where we had 3 times more new infections than what was the target for UNAIDS and WHO. And if we go down at this, continue going down this trajectory, we will also miss the target for 2025. If one then zeroes in down on the epidemic in some of the hardest hit countries, and this is data from South Africa, from our own Africa Health Research Institute, you can see that in some communities are very heavily impacted by HIV. So for example, in this rural community in KwaZulu-Natal, the prevalence of HIV is at 40% in men between the ages of 25 and 44, and more than 60% in women. So even if we were able to stop new HIV infections today, these individuals will have to live with HIV for the rest of their lives, and will have to take antiretroviral medication daily for the rest of their life, which is the only way to deal with HIV at the moment. And so I think this provides us with the rationale for seeking for an HIV cure. I think the other reason is that there are HIV-associated morbidities associated with HIV infection, even when people are on fully suppressive antiretroviral therapy. So we know from data published that the risk of cardiovascular disease, metabolic disorders, neurocognitive abnormalities, malignancies, and even life expectancy is much worse for people living with HIV, even when they're on fully suppressive antiretroviral therapy compared to their HIV uninfected population counterparts. So why is it so difficult to cure HIV? We know that when somebody is on antiretroviral therapy, the viral load goes down to undetectable. and that antiretroviral therapies can suppress the virus for many years. But as soon as the antiretroviral therapy is interrupted, the virus rebounds within a few weeks. And the reason for this is because of what you call an HIV reservoir, which is composed of latently infected cells that persist despite antiretroviral therapy. So how do we get rid of this viral reservoir? Scientists, I think, have two general approaches for doing this. One is to completely eradicate the reservoir, and this can be done through gene editing, latency reversal, and strategies such as block and lock. But this strategy of completely eradicating the virus is problematic, particularly for low and middle income countries, because of the complicated nature of these procedures in order to achieve complete viral eradication. And it's also not really safe, at least at the moment. So the alternative to that is to induce what we call an HIV remission. And this can be done by gene editing, latency reversal and block and lock strategies, and then controlling the virus through the immune system. However, we know that even when this happens, remission is variable and there are no biomarkers that exist to predict success. However, we know that when people have gone into remission, this has happened when combination or when antiretroviral therapy was initiated in acute HIV infection. And such successful approaches of remission have involved enhancing or boosting anti-HIV HIV immune responses. So with this in mind, we thought that we could attempt this kind of approach in sub-Saharan Africa, and we established a cohort that we call FRESH, Females Rising Through Education, Support and Health. In this cohort, we enroll women who are at high risk for HIV infection between the ages of 18 and 23. We combine a basic science research program with socioeconomic empowerment, where we try to prevent new HIV infections. But at the same time, the participants come into the clinic twice a week, and we test them for HIV RNA test through a finger prick blood draw. And because these women are all HIV negative when they enter into this program, if they become HIV infected, we can immediately detect acute HIV infection. In most cases, when phobic stages 1 and 2 of acute HIV infection. And then what we have done is to proceed to put these women on antiretroviral therapy. And initially, when we started this cohort, the first 14 women that we identified were not put on treatment immediately, because the South African treatment guidelines at the time called for the initiation of treatment when CD4 counts fell below 350. But subsequently, we started treating all the women, and most of them are put on antiretroviral therapy within a day of detection of acute HIV infection. And you can see here in this graph, in the bars with the blue and red, are the women who started treatment in acute HIV infection. And you can see that within 5 weeks, almost all of them have completely suppressed the virus to undetectable. And you can also see that their peak viremia is much lower compared to the women who are not put on treatment immediately. And what we also realized is that this approach also preserves CD4 T cell counts. So you can see that the NADA CD4 T cell count in the untreated women is much lower compared to the women that went on antiretroviral treatment immediately. So we have used this cohort to understand the nature of the virus that is transmitted. And this phylogenetic tree here shows that almost all the women were infected with very homogeneous viruses when we sequence the transmitted founder virus, suggesting that there is only one single variant or a very limited number of variants that are transmitted. And what we have also done is to take some of these clones of the transmitted founder virus and generate clones, and then test to see whether these viruses can be neutralized by broadly neutralizing antibodies. And this data here shows the neutralization capacity of the viruses by broadly neutralizing antibodies that are readily available to us. So we tested them for sensitivity to broadly neutralizing antibodies that are listed here. And you can see some of these broadly neutralizing antibodies here. And what we noticed is that the two best broadly neutralizing antibodies for this cohort, at least, were VRC07, 523LS, and CAP256. And these are the two broadly neutralizing antibodies that we think could be used to attempt an HIV cure in these women. We have also characterized the reservoir in these early treated women. And the first thing that we noticed is that, as I mentioned earlier, is that when you start treatment in acute HIV infection, you blunt peak viremia. But interestingly, the peak viral DNA in the cells is not impacted by early antiretroviral therapy, such that the peak DNA levels are the same for untreated women as compared to the acutely treated women. So early antiretroviral therapy does not appear to impact the seeding of the reservoir. However, when you continue with treatment, after 1 year of treatment, you can see that the reservoir is lower in the acute treated women compared to the women that were not treated during acute HIV infection who initiated treatment in chronic HIV infection. So what are we doing with this data? This data has led us now to an HIV cure intervention in these women, where these women who started treatment in acute HIV infection are being treated with the two broadly neutralizing antibodies that we identified as the best for this cohort. And we also give them an immunomodulatory agent, a toll-like receptor agonist 7. And then we interrupt treatment to see whether the virus rebounds or not. And our goal is to try to understand whether this intervention can lead to long-term remission, and also to try and understand whether, if this strategy that does not work, why does it not work? And so
you may have seen that we have a clock running, which just gave the alarm.
Unfortunately, yeah.
So
sorry,
can you finish your
that.
presentation in like 1 minute?
Yeah. So let me finish very quickly to say that we are now doing this analytical treatment interruption cohort. And just to finish, I wanted to say that I think from our perspective and from our experience, what is needed to accelerate HIV cure research in low and middle income countries is more research funding. Obviously, we need infrastructure development, laboratory and clinical infrastructure, community engagement, as well as capacity building. And we have a consortium called SANTE, which is attempting to do this in low and middle income countries. This consortium is interested in research, leadership development, and institutional strengthening. And we work in 8 different African countries that are shown there. And we are funded by many funders that are listed there. And I would just like to thank my colleagues who work with me in this work. Thank you very much. I'll stop there.
Thank you so much, Tumi, and thanks for sharing the wonderful work that you're doing with the Fresh cohort there. So to the audience, we welcome your questions, and I'm sure you will have many after Tumi's presentation. We'll take them all the way at the end of the meeting during the panel discussion. So I would now like to invite Monique Nijhuis. Monique Nijhuis asked me specifically to keep the introduction short, so I'm just going to say that Monique is associate professor in Utrecht, as well as professor in Joburg with Waterschot. And Monique is, I'm sure, going to tell a bit more on also the Spiral project that we recently started. Monique, the floor is yours.
Thank you very much, Remco, for this indeed short introduction. So that's good. It leaves more time for content. So thank you for the invitation to discuss the scientific priorities for funding an HIV cure. We discussed them also together with Tumi. So I'd like to give like a little bit of more of an helicopter overview of what we feel are important areas of research. So if we have a look at the HIV cure landscape, you can see that everything is centered around people living with HIV. And if you think about biomedical interventions, just as Tumi already indicated in the first presentation, you can think of remission, which is a durable control of HIV infection, or you can think of eradication, which means that HIV is gone and there's no rebound competent virus. The question is, of course, whether long-term durable control may result in the end in eradication. That's something that we do not know at the moment. If we are thinking about biomedical interventions, I think it's also important to think about potential reinfection. Of course, the importance of coming up with a cure intervention that will also prevent reinfection depends on the context people with HIV are living in. So for that, also, I think social and ethical aspects of HIV cure are really central if we are thinking about the HIV cure landscape. And finally, HIV reservoir. I think that's also really important because the HIV reservoir forms the major barrier towards HIV cure. And we also need some kind of a measure of the viral reservoir as a measure of success of the biomedical interventions. So let's start with the HIV reservoir. If we are thinking about HIV reservoir research, I think it's really important to characterize the rebound competent viral reservoir. So where is this virus hiding? In which particular cells? Do we have to look at T cells? Do we have to look at macrophages, or maybe even other cells that we are currently not aware of? Are there differences between people with different HIV subtypes? Are there differences between male and female? We've performed an initial analysis in Africa because this presentation really focuses on the research that we are doing in Africa. And we've done an analysis, FIND 1 and FIND 2, with the help of the Southern African MRC and also with help of the AIDS funds. So basically what we did is that in more than 70 individuals with HIV who passed away, we performed an ultrasound-guided core needle biopsy, as you can see here. We looked at all the different organs and we developed an assay to quantify presence of HIV DNA. And to make a very long story short, what you can see here is that HIV can be detected to different extents in all different organs, including the central nervous system. And of course, the levels depend a little bit on the type of organ and also whether you were suppressed at the moment of dying, yes or no. So this is really important, and as Remco just indicated, we started the Spiral project, and I will allude on that a little bit more during this presentation. And within the Spiral project, we will perform a more profound characterization of the viral reservoir, because here we look just at the presence of HIV DNA, and then we will look whether the DNA is intact and whether the DNA could potentially rebound from those archives. So having said this, it's not only important to characterize the reservoir, but also to quantify the reservoir in such a way that it can be used as some kind of a biomarker for treatment success. And for that, it's important that we are thinking about high throughput assays for clinical studies. And those assays should also be able to detect different HIV-1 subtypes. And in addition to that, I think it's really important to also think about point of care viral monitoring, maybe even home monitoring, if we are thinking about clinical studies in which we would like to interrupt treatment. And also there, we have to keep in mind that if we are thinking about an HIV cure for all, that we also have to include assays that can detect different HIV-1 subtypes accurately. So having said this, I really would like to have a look at the different interventions. Tumbi just alluded on this already. There are basically 3 different kinds of cure interventions that people are currently working on. The first one really is to try to limit the establishment of the reservoir. For that, you really have to identify people during acute or maybe even hyperacute infection, just as Tumbi was explaining for the fresh cohort. In addition to that, you have 2 other strategies. First one is to reduce the size of the viral reservoir. You can do so by flushing out the latent reservoir, for instance, with latency reversing agents. You can try to deplete your infected cells or render the uninfected cells resistant to HIV. And finally, you can use all kinds of immune control systems like vaccine or maybe antibodies to control the viral reservoir. What I would like to do is to focus for one moment on the first patient cure of HIV infection. I think known to everybody, Timothy Ray Brown. He really provided hope to the whole community. And what happened in Timothy Ray Brown is that he not only was diagnosed with HIV, but he also developed a malignancy. And for that, he required an allogeneic stem cell transplantation. And he got cells from a very special donor lacking CCR5, which means that those cells are very hard to infect with HIV. So what you do in such a particular strategy is that you deplete the infected cells because you treat the individual with chemotherapy or with total body irradiation. But at the same time, if you give these specific cells, you also render the uninfected cells resistant to HIV. And that's exactly what happened. So based upon this, we started the ICSTEM program, and the ICSTEM program focused on people with HIV undergoing such a transplantation because they suffer from a hematological malignancy. And we want to do so because we would like to understand which factors are now important for the elimination of the viral reservoirs and important for remission and even eradication. Not because we think that we're going to cure 38 million people with stem cell transplantation, because this is not scalable. But we do think that the knowledge is important to come up with such a scalable cure intervention. So far, we included 50 individuals, and we are still including new people. So here you can see Timothy Ray Brown, the Berlin patient, and we're really happy that in addition to Timothy Ray Brown, now in total 5 people have been cured of HIV infection, including patient number 2, the London patient, and the Düsseldorf patient, both from our ICSTEM cohort. In addition to that, also 2 patients in the United States. And what I really would like to share with you is very hopeful news that we presented last year, or actually this year, on the IES in Melbourne, in Australia. And what we showed there is that there's now also an individual, the so-called Geneva patient. He was transplanted with wild-type cells, so not with cells lacking the expressor, but wild-type cells, interrupted treatment 2 years ago, and there was no viral rebound since. And we are currently investigating the underlying mechanisms. So just as an example of what we are doing with the interventions. So let's have a look at the really important social and ethical aspects of cure. We really think that we should expand community and stakeholder engagement and develop a cure with equity, representation, and global scalability. And we also think that it's important to work on capacity building in research limited settings, not only in the South, but also in research limited settings in the North. And we strongly feel that social, behavioral, and ethical research should be an integral part of HIV research. And as such, I'm really very proud to present to you the Spiral project. It was already mentioned by Remco. This is a project that just started 2 weeks ago, let me think, the 1st of December. And it's an integrated interventional program to achieve durable HIV control in diverse populations. And I think it's very unique in the way that we collaborate. I mean, it's countries in the North, countries in sub-Saharan Africa. We have combined expertise in virology, immunology, and gene therapy. And as you can see here, also community engagement and engagement of the pharmaceutical industry. The focus within this project is really on those people who need HIV cure the most, women living in sub-Saharan Africa. So we focus on differences in the viral reservoir in treatment strategies between men and women, and also between different HIV subtypes. And we do so from bench to bedside. And with that, I think we will be instrumental in achieving an HIV cure for all. So I would like to thank all the researchers, as you can see here, who are so important in our ICSTEM project. I'd like to thank AMFAR for previous funding and AIDS funds for current funding. I also like to thank the people in our lab in translational virology in the Netherlands, and our colleagues from the University of Witwatersrand that were very instrumental in conducting FIND-1 and FIND-2 studies. With that, I would like to thank all the funders and especially all the people participating in the studies. And that's basically my presentation. And I see that I'm in time, so that's good.
Thank you for that.
Perfect
Monique.
timing.
Yes, so nicely in time. And also thanks for giving some names to HIV cure with the examples and the stories of Timothy, Adam, and Mark. I think it's really important and inspirational to see with the work that you have done there. For people in the audience, you may have heard a lot of technical terms in the last two talks. So, if you heard Monique talking about my biomarkers, feel free to ask her in the chat which biomarkers she has looked at. But if you think, what the hell is a biomarker and what should I do with it? Tell me when we have a cure. You can also raise that question in the chat. The main message here is don't be afraid to ask your questions. With that, we're going to switch gears. We're now going to have the panel on funding. And with that, I'll give the moderation microphone over to Mason.
Thanks, Remco, and thank you so much to our scientists and experts doing work on this. I think there are probably a few of us who are wishing we'd taken more science classes at university, but I'm super grateful for those who are seeing these breakthroughs and learning from these 5 people who have actually cleared HIV from their system even after medication is in. It's really just remarkable. That work doesn't happen by itself. It needs support. And so we wanted to turn to funding and what that environment looks like to see kind of what kind of support is going into this. Where are we? What does some of that funding look like? We've got a few people to speak on that now. And to give us some of the latest data, I'd like to introduce Shiva Muzaffarian of AVAC to kick us off. Can you join us? Thanks, Shiva.
Hi, everyone. Thank you so much for having me. Sarah, are you able to show my slides, or do you need me to share my screen?
You should have control, so you're welcome. There you go.
There you go. Okay, awesome. Well, my name is Shiva Muzaffarian. I use she, her pronouns, and I'm the data analytics program manager here at AVAC. So I help to run R&D resource tracking for HIV prevention, HIV cure, and STIs. The latest data we have for cure is for 2021. So I want to just walk you through what this latest report shows. So a little bit about methodology and background here for the latest report. This has been a collaboration between AVAC and IAS. We joined forces about a decade ago to collect estimates and provide the field with important trend data. Data on cure research grants is collected via public information and direct appeals to funding agencies. And we use the cure definition developed by the NIH's Office of AIDS Research. Just a quick note here that while surveys are sent to potential cure research funders in the public, private, and philanthropic sectors, responses from private entities are most difficult to obtain, which leads to an even greater underestimation of commercial investment in cure research. So something to know as we look at some of these numbers here. So what did the data show? Total funding went from 337 million in 2020 to about 440 million in 2021. So this is a huge growth, 30% year over year. And it also represents a 5-fold increase since tracking began in 2012. So we see this steady increase throughout the decade. And this is great news. It shows that there's a growing sense of urgency, scientific opportunity, and funding around cure research. So just to get a little bit more into detail here. So here's just highlighting the priorities in the HIV R&D field at large. While cure research funding has grown significantly throughout the time we've been tracking the field, approaching almost $500 million in 2021, both HIV prevention and HIV vaccine R&D funding declined. Prevention dropped by 5% and vaccines by 6% throughout the same time period. I do want to just bring to note that another methodology point here is that we don't double count grants across HIV prevention and cure R&D. So there are some technologies that could arguably count as both vaccine and cure research, for example, with BNABs. So we defer to the funders that report, but just note that this could impact some of the numbers that you see. So let's look at funding by sector. Consistent to what we see across most of global health, funding is consolidated around the NIH and the Gates Foundation. So the majority of investments here, 362 million, came from the public sector, with 41 million invested by philanthropies such as AIDS funds, AMFAR, Gates, the Campbell Foundation, Pasteur Institute, SitAction, and the Wellcome Trust. And as mentioned, only a few private companies responded to our 2021 survey. So this 37 million is most likely a significant underestimation for commercial investments in cure research. As you can imagine, capturing this information is extremely important, and we're, of course, super grateful to industry who do report to us. I do also just want to take a moment here to say that you don't need to be one of these top funders to make a difference in the field. You'll hear from Jeffrey Lawrence at AMFAR in a few minutes, but they're not the largest funder compared to the NIH or Gates, but they've been catalytic in what they've done over many years. And this is true for long-term donors such as AMFAR, but also out there, any of you on the line, if you're interested in cure research, small amounts of money can innovate and move the field forward. So I don't want you to be discouraged by these numbers. Let me switch, sorry. So here, this shows funding by stages of cure research, which, as you can see, is overwhelmingly concentrated in basic and preclinical phases in 2021. So HIV cure research is mainly upstream, but I also just want to note a recent analysis here by TAG that found that a broad distribution of research in clinical trials were phase 1 and phase 2 studies, and that the majority of cure clinical trials focused on gene therapy and antibodies, both in combination and alone. So that's some of the breakdown here by research stage. So here we have the HIV cure investments by country where investments were generated. I'll talk a little bit more about the trends on the next slide. I do just want to take a note here that this doesn't necessarily show where the research took place. In fact, we know that there's a disconnect between the participants in cure research and the demographics of people living with HIV. So most of the studies are not being done in areas where the burden of HIV is highest, and it's crucial to conduct research amongst affected communities and enable stakeholder engagement. And we're really working with TAG and IAS to make sure we capture this information in 2022 and moving forward. So here, this just shows that the 2021 data showed sustained geographic diversity in cure R&D, with several countries joining the US to increase their funding. So we have Canada, Switzerland, and the Netherlands, and this increase in funding by these countries in part accounts for the significant growth observed. This is great news, but we obviously still need to work on diversifying the funding base. And let me just get to my last slide in the next 20 seconds. So what are the key takeaways? We touched on this briefly, but only 6% of research sponsors reported participant data derived from trials conducted in African countries. So there's a growing recognition that research needs to be done among affected communities, and the establishment of the HIV Cure African Acceleration Partnership aims to enable this type of stakeholder engagement. And lastly, I just want to mention the expansion of the NIH-funded Martin Delaney Collaboratories, started in 2011 with 3 collaboratories, and now there are 10. And for the very first time, we have some focusing on pediatric cure research. So this is just some of the great examples of innovation that we've seen as more resources come into the field. That's all for me. Sorry for being over. We really just hope these reports are helpful. And if your organization is a funder or recipient of HIV prevention or cure grants, and we don't know you already, please just reach out to us at HIV resource tracking at avac.org. And thank you so much for having me.
Shiva, thank you so much. And I just want to especially do a shout out and appreciation for recognizing how important even small grants or smaller grant making is in this space. Whether somebody's making a catalytic investment in research or supporting community groups on the ground, you don't have to be one of the biggest funders to really make a difference in people's lives. So thank you for highlighting that. I want to turn to the funding and leadership of an amazing partner in AMFAR, and welcome Jeffrey Lawrence to share some of the work that they've been doing.
Thank you very much. So AMFAR has been involved and interested in HIV cure research since the very, very beginning of the HIV epidemic. to the point where our co-founder, Dr. Krim, sometimes would be criticized by activist communities. Cure was a 4-letter word. Why are you focusing on cure when there's so many other things that need to be done? We have 3 basic mechanisms to fund research at AMFAR. One is a larger group of grants called the ARCH grants. There's no request for proposals here. Applications are typically invited for a project, but all of those invitations are based on ideas that are developed in our think tanks. And I'll talk about those in a moment. Typically, we run 4 or 5 a year, half nationally, half internationally. Awards are based on needs and funds. I'm going to show you a couple of examples from this year's awards that have ranged up to $2.5 million. We then have our more typical grants where RFPs are released semi-annually in January and June. These are typically much smaller grants, $100,000 for 1 year, up to $400,000 for 2 years, plus 20% indirects. And then we have the Matilde Krim Fellowships to fund young investigators early on in their career in HIV research. These are 2 examples from our summer 2023 study. One, an ARCH grant from Dr. Hildegard Buning, and Hans-Peter Kim's a regular grant. To show you the kinds of ideas we're involved in here, Hans-Peter Kim's grant focuses on the idea that, we're talking here about an HIV cure for all. If we need an HIV cure for all, we want something that's probably portable, that's probably going to be involved gene therapy, and that should be a one-shot deal. We don't expect to be able to find everyone and get them back for a second shot or a third shot or 15 shots of a vaccine. And Dr. Hans-Peter Kim is developing this based on his use of engineered virus-like particles, introducing genes into stem cells. Dr. Buning's grant, and we've already awarded her almost $3 million, is a large preclinical study involving non-human primates, which is a multimodality study where we include antiretrovirals plus bNAbs plus gene therapies and CAR T cells, throwing basically everything at this issue. But it shows the range of grants that AMFAR can offer. Importance of think tanks to our mission, a brief history. This actually started all with our first think tank in 2008, where we invited Dr. Hutter to come and talk about this amazing finding that he found. I couldn't understand why the world wasn't jumping up and down about this. And the nice thing about our think tanks is that we're allowed to invite one journalist. Typically, it's a journalist from Science. John Cohen has been to a bunch of them, or Nature Medicine. This time I invited a Pulitzer Prize winner for his work on AIDS reporting in Africa, Mark Schufts. We talked about this. Obviously, you can see people from the NIH, industry, academia. And the following week, the Wall Street Journal published a report on this. The case was presented to scientists earlier this year at CROI, the nonprofit foundation. AMFAR convened a small scientific meeting on the case. The scientists agreed that the patient is functionally cured. Well, what does the world think of this? Well, a week later, the New York Times feels left out, so they publish a quote from the NIH. It's very nice and not even surprising, Dr. Fauci said. So Dr. Fauci was nonplussed about this, but he did say something important, and that is, but it's just off the table of practicality. Yet doctors say the case gives hope for therapies that artificially induce the Delta 32 mutation. So what are we going to do now? Well, we start more think tanks to try to attack this problem. The very next one after this was to see if we could promote the generation of stem cells that have been genetically modified. That is, I know that we can't infect 100% of the cells 100% of the time with any vector and cut out all the genes or add genes we need to, but maybe we can do 100% of the time in one cell, amplify that cell. This didn't go a lot of places back then, but it's still a possible means. We talked about pediatric issues because people are often in the talk of cure leaving out pediatrics. And then we decided, and it was thanks to Monique for pointing this out, basically we decided that another cure, a proof of concept that we just don't have one, but we're going to get the second, third, fourth, and fifth patients, will never happen in the United States, or certainly is not going to happen easily in the United States because of issues with insurance, because of issues with large funders not basically interested in this program. So we called together a consortium of European organizations to say, we know it can happen in Europe. It's already happened once. Let's do it again. And that's where the ICSTEM proposal came from. This one was held in Amsterdam. We did a follow-up one in Munich, a follow-up one to that in Barcelona to try to get as many transplanters involved as we could. And then ICSTEM was formed, and we talked about progress reports in Dublin just a few years ago. And this is basically how the Berlin patient and the Düsseldorf patients were partially supported. So what are we going to do next? Well, it's in getting the ideas for the other proposals that I mentioned, like Hildegard Booning's study that we funded to almost $3 million. Give us other ideas. So we called a think tank together at the MIT Endicott Center to discuss possible means, to discuss block and lock, to discuss better latency reversing agents, to discuss BNABs. Role of antibodies was the focus of a single think tank a few months ago. And actually, this one led to our newest RFP and request for proposals, and we're currently evaluating them now. So basically, I don't want to get into Mike's program. So basically, the concept is that AMFAR has very rapid funding. We can go from a think tank like this in April to inviting proposals in June to funding those proposals in August or September. We are flexible in terms of money, standard grants between 100 and 400,000, but you could see that our last ARCH grant was almost $3 million. And we take very risky, innovative ideas. We're very proud of starting this all off, announcing the Berlin patient to the world, convincing the world this is important, to help Monique and her team form the ICSTEM consortium. And actually, we were lucky. We here at Cornell published a fifth cure used in a woman of mixed race, using a very innovative technique developed in Belgium and pursued here at Cornell of doing haplocord transplants in order to provide transplants to people of unusual genetic backgrounds, meaning non-Caucasian people, the possibility of a transplant cure. And I will stop there.
Thank you so much, Jeffrey. I really appreciate the reflections and the AMFAR's approach of taking being in this for the long haul. You've all been working on this for a while, being willing to take risks and having those really pretty rapid response grant opportunities for this work. So thanks for sharing that. Another key player in this work has been the Bill and Melinda Gates Foundation. That has been, really one of representing almost a third of worldwide grant making and philanthropy around HIV, and doing a lot of work around research and the cure. And really delighted today for Mike McCune to join us to give us an overview of the Foundation's HIV Frontiers program. Mike, can you join us?
Yeah, thanks, Mason, and thanks to FCAA and AIDS Fund for putting this important webinar together, and all of you for joining. I'm actually going to be talking about a program that began at the Gates Foundation about 5 years ago. Most of the money from the Gates is going for prevention and treatment. This program, HIV Frontiers, started about 5 years ago to look at cure. And our goal is to bring safe, effective, accessible, acceptable single-shot curative interventions for HIV, and I'll explain to you also sickle cell disease to resource-limited parts of the world, by which I mean the global south and resource-limited parts of the global north. And just by way of summary, if I can do that, great. This is all you need to know. So the curative interventions we do think for sickle and HIV can, by gene therapy, be brought to hematopoietic stem cells, the mother cells of all the blood system, in techniques that are compatible and translatable from one to the other. And because the burden of disease for both HIV and sickle, especially in sub-Saharan Africa, is so high, we're really keen to tackle both. And we know that we can't do it alone. So from the beginning in 2018, as we've been setting forth, we've been trying to gather partners along the way, and I'll explain to you the program really that we're trying to pursue. We're interested in this because there have been some amazing advances in science over the past decades. You probably heard last week, two therapies, curative therapies for sickle cell disease, gene therapies, were approved by the FDA. Everybody now knows about messenger RNA and lipid nanoparticles. My mother can talk about them with fluidity, but I think the COVID pandemic has also shown us that there are tremendous disparities with respect to healthcare around the world that need to be fixed. The type of therapies that we wish to pursue for HIV and sickle are common in some degrees, in the sense that they're single shot across the arm, in and out, outpatient, safe and affordable. We're looking at a price point of $1,000 to $2,000, not $2 to $3 million in sub-Saharan Africa, for HIV to be cost effective, or cost equivalent, at least with ART. And for HIV itself, on the right, we want to bring the viral load down and make it last for a long time. And Monique mentioned the important attribute that that whatever we do prevents reinfection, because we're not going to be able to change behaviors. And we believe also that we need to have a marker, a biomarker, that will allow us to look for remission. We now have really two interventions. It's grown, right, the way science is, and several enabling activities that the team is focused upon from the left to the right. In vivo gene therapies for sickle and HIV, we tried to de-risk the formidable problem of targeting hematopoietic stem cells by incentivizing work with known methods to fix sickle. 5 years ago, we didn't have a clue about how to fix HIV, other than, for instance, to knock out CCR5, which would not prevent reinfection. We've learned over the past 4 or 5 years, too, that therapeutic vaccination might offer a single shot approach towards durable antiretroviral free suppression of HIV, not applicable so much to sickle. I won't talk much about, but we've set up a heavily resourced 9-team, 30-lab, 4-continent program to understand more about the biology of the rebound competent reservoir of HIV. And although we haven't been able to do this as much as we would like, we know that we need to build capacity and engage key stakeholders in all parts of the world, so that when this aspirational program ever is to come to the field, it's acceptable, and it's something that people will use. Over the past 4 or 5 years, in the context of gene therapy and vivo gene therapy, we've provided about 40 or 50 grants to academic labs and non-academic labs, for-profit companies, usually $1 to $3 million, with metrics, milestones that are quite specific. And most of those have failed, going through this sieve into humanized mouse models and non-human primates, with other criteria that are important for selection, including the safety of the method that's being used, the ability to develop it in large scale, the team with which we are working, and perhaps most importantly, the ability of the group, be it academic or non-academic, to provide global access for low and middle income countries. That is to say, non-exclusive rights to use the funded developments for sickle and HIV, or HIV, in those geographies, without which I think we won't move forward. The summary of the program today, as it stands, is that we have engaged, after all of this activity, 6 companies and several more that we are in the process of working with equity investments and grant investments, or a mixture thereof, to pursue either in vivo gene therapy for sickle cell disease, that's Novartis or Insoma, or in vivo gene therapy for HIV disease, including CRISPR, BioNTech, Immune, and Addition Therapeutics. I won't go into the details of how they're doing this. It's a diverse set of companies doing diverse things, but they're all moving forward. And for therapeutic vaccination, we've engaged 3 companies, Vir, BioNTech again, and Immunocore, to develop diverse ways to provide single-shot therapeutic vaccines, or derivatives thereof, to HIV-infected individuals. The Reservoir Biomarker Program is now engaging, as I mentioned, a large number of groups in both academic and for-profit companies, and we've also begun to engage a number of key stakeholders around the world to build this very important process of capacity building and stakeholder engagement. We felt fortunate to be able to join with the NIH from the beginning in 2019. I think Carl will talk some about that, but it's been really good for us to be able to transparently look back and forth across our portfolios. The 6 to 8 programs that we now have in place, we believe over the next 3 to 4 years will move asynchronously but forward in a way that some will look good and others won't. And we imagine that after a period of time, and really it's not too far on the horizon, we will be able to sift this down to a smaller number of programs that will go into first-in-human studies. We see for HIV that there's a potential payer, hopefully, in the way of PEPFAR, but we are still struggling to understand what the payer, we can talk about this later, will be for sickle cell disease. The next 4 years are critical. They're not years that are going to be funded by the normal funders, and they're not the kind of funding mechanisms that venture capitalists will embrace. And so we're going out for philanthropy. The foundation and the leadership is really eager to get this happening, but is not able to do it alone. And so we are going out to join in partnership with other funders. We've estimated that we need about $400 million to get into first in human. The foundation can provide some of that and is willing to match others. So our approach towards funding is to leverage funding from donors of high net worth, okay? And in order to do this, we've engaged the philanthropic fundraising arm of the Gates Foundation, and they made some really nice slides, and I'm just going to go through very quickly. And this is what I show to people on street corners now, and if any of you want to get the show later face-to-face, I'm happy to talk about it. We talk about what the problem is. I think a lot of people don't know yet. Still, they forgot, whatever, that there are 39 million people living with HIV. Even in the United States, only half of those are able to stay on antiretroviral therapy and remain suppressed. That's a problem. And, you know, it's, as Toombi pointed out, it's the numbers are even worse in some other countries. We talk about the opportunity, about the fact that it is possible now, using the wonderful science that we have, to either genetically modify cells such that there will be durable clinical benefit provided in the case of HIV and sickle, or a therapeutic vaccine. And there might be the ability, as we have done almost for polio, and certainly for smallpox, to get rid of this pandemic once and for all. We talk about what a cure would look like. And we really make the point that it's going to be a single shot. Medicine doesn't work, generally speaking, because people have a hard time taking pills every day, especially for chronic diseases. It's just not even for hypertension, for hyperlipidemia, et cetera. So we talk about this as a novel way to provide medicine in a way that can be done now. For sickle, we know that we can treat, we have 4 or 5 different ways that we can treat sickle using ex vivo gene therapy, where the cells are taken out and then put back in. And we're picking those ways up now to do that in the body for sickle cell disease. And we think that the targeting for HIV will be very similar, actually, with some ideas about how to do that. We talk about therapeutic vaccination. People understand what an LNP mRNA vaccine is now for prevention. The order of business to do this for therapy is actually quite different. And in many ways, I'm not going to say easier, but more straightforward. You're actually taking somebody that has an illness and giving a vaccine to prevent the illness from progressing, and also taking them off antiretroviral therapy. We point out that after 4 or 5 years of really many shots on goal that we've tried, many of which have failed, that we have a much more clear vision of what can work now, and that we want to move forward into proof of concept through a valley, if you will, which is not normally funded by the usual funding mechanisms, and that we want partners to help us in this process. We give options. I'm sorry, the foundation is looking for really donors of high net worth that can provide larger sums of money against which we can match, so that we can do things, and we outline what those things might be. And then I also give them my phone number or my email. And that's the approach we're taking. I feel hopeful.
Thanks, Mike.
That we'll be able to do this. I hope I didn't run over time. I didn't see the.
Just a little bit, Mike, but thank you
Sorry.
so much for sharing that work that you all are doing, and the timelines you're working with. And we need more venture capitalists, I think, in this space. So hopefully we will be able to get some more movement, and appreciate all the work that you're doing. I'm going to turn it back to Remco, but first, a quick reminder that if you have questions, please put them in the Q&A or in the chat function, and we will come back to those at the end of the session.
And Mike, can you stop sharing your screen for me so I can move over to the others?
Sorry, yeah.
That's okay.
Technical. There you
We're
go.
going
Is that
to
good?
change gears again and move into the third panel, which is about community engagement and advocacy. And that I always like personally about the area of HIV research. I've worked in other therapeutic areas where HIV community engagement is much less developed. We're very happy to have Susu Sikanje from the Infectious Disease Research Center in Zambia to take us through this topic in the next 10 minutes, and then we have 20 minutes for an overall discussion. Susu, the floor is yours.
All right, thank you. Good evening, good morning, good afternoon, everybody. I hope you can hear me okay. I'm having a bit of bandwidth issues, so I'll turn off my camera so I don't have any interruption, but I'm happy to be here and be part of this webinar. So I'm going to talk about some of the work that we've been doing around community engagement and advocacy. And really, this is important because when you look at the HIV epidemic, the prevalence, the incidence, and the work that still remains to be done, the bulk of it is right here on the African continent. And you can see the countries in the really dark red, maroon color. That's where the bulk of the problem is. So if the problem is here, then we really need to have focused engagement, both from research advocacy as well as community engagement happening here on the continent as well. And when you look at the clinical trials that are underway, in terms of cure research, this is data from the TAD pipeline as of, I'm sorry, my slides are taking a little bit of time to move, so forgive me for that. But when you look at the clinical trials that are underway, data from July this year show that there were about 123 clinical trials, observational studies along HIV cure, and only 11 of these trials were in Africa. You heard a little bit about them from the first two speakers, Tumbi and Monique. And unfortunately, only about 3 trials were concentrated around the pediatric or adolescent population. There's still a lot of vertical transmission, so we still have children being born with HIV right now, despite there being an intervention that can eliminate vertical transmission of HIV. Another thing I wanted to point out that is that the epidemic here on the African continent is concentrated amongst females, but you see in the clinical trials, they only have about 18.2% of females in those clinical trials. So therefore, a lot of issues or challenges that women face are not really taken into consideration when you look at the HIV cure trials. And so far, about 18% of participants in the trials are Black. And as you know, here on the African continent, the majority of our population is actually Black. So despite all this and the bulk of the cure research being done outside the continent, we're saying that Africa is ready to take on this work, and it's ready to do a lot more than has been done already. And this work is being done in solidarity with our partners in the global north. I want to stress that we would not be where we are today had it not been for the real meaningful partnerships that we've had. On the right-hand side of my slides, you will see some of the captions in daily newspapers in East Africa. The top one is from Tanzania, where the government was really hopeful for sickle cell cure. This is post all the evidence and some of the cure that has come through for sickle cell. And in Uganda, scientists led by Sisi Kyoto and others have worked really hard to push forward the genetic modified organism bill that is intended to improve health, food security, and foster development. So they've really tried to work with their governments to see how they can move the needle when it comes to genetic therapy. So we are building momentum by leveraging and expanding existing African cure leadership. And I'll show you some of these examples in my coming slides, as well as ensuring that we build communities that can demand for the cure research, as well as for products to be made readily available here in Africa. I know this has been said over and over again, but COVID did teach us a very harsh lesson here on the African continent. So we're working also with various sectors, multi-stakeholders, to ensure that we're able to influence and shape policy that will be able to allow the access and feasibility and implementation of cure research as well as cure products, and ensure that there's a positive ecosystem that will support that work. So some of the work that we've been doing, I'm just waiting for my slides to move forward here. I hope you can hear me okay. So some of the work that we've been doing here has been around developing our, I'm sorry, I'm having slide issues. I'm moving too slowly and then I'm speaking too fast. Well, we've been working through making sure that we expand our researchers, and Tumbi did show you some of the work that they've been doing with the Sante Consortium, working across 7-8 countries, and they've trained over 100 professionals, and some of these have been at postdoctoral level. And what is important is that a lot of these have been retained in academia, and many investigators are leading some of their own grants as PIs. So we really applaud this work in terms of getting the science right here in Africa. We've also worked hard to engage with communities, and I've seen in the chat there's been talk about JoJo, the community cure resources. So I do hope that you follow the links that have been put in the chat about the cure resources. We've also worked with other community experts and advocates that have been pushing the needle when it comes to community engagement on the research agenda. And I've put Moses there as one of the exemplars that we've worked with, but the others right here in Zambia as well, and down in South Africa, working with the youth. This is Impact Drivers that really worked a lot with community engagement and building interest in science, technology, engineering, and mathematics among school leavers and social media influencers, so that there is more interest in science and research. So to lead on, I'll talk about some of the policy work that has been done has been led, like I said, by Cici, and she's done this in partnership with Jennifer Adair. They have put up the Global Gene Therapy Initiative that was founded in 2020 to essentially close the gap between gene therapy development and access in LMICs. So they're looking both at sickle cell disease and HIV work, and I think Mike talked a little bit about that in terms of the work that they're doing addressing both diseases, given that both these diseases are quite prevalent here on the continent. And some of the early lessons from the GGTI group is that there have to be target areas to be identified to bridge the divide between gene therapy access and conduct. So they'll be looking at doing phase 1 and 2 clinical trials in Uganda and in India by 2024. And they're really working hard on capacity building. They have postdoc fellows training in the Fred Hutch labs with Jennifer Adair. And then Uganda is being used as the test case for implementation of genetic engineering governance with support from WHO. So really looking at the policy landscape. And some of the initiatives that I've been involved with around cure collaboratives and here on the African continent have been through 2 main vehicles: the HIV Cure Acceleration Partnership, HCAP, and the recent initiative that I've been really happy to work with, the HIV Community Engagement and Research Collaboration. So I'll talk very briefly about these 2 initiatives. So HCAP was essentially born out of work over several years and was, I guess, formally put together in 2019. And what it does is bring in various stakeholders. As you can see on the right-hand side of this slide, there's a cartoon there with various stakeholders that include philanthropy, pharma, research, as well as policymakers here on the African continent and beyond, to come together to promote dialogue among key stakeholders to accelerate the availability and delivery of an HIV cure. So the vision of HCAP is work towards a single-shot HIV cure through an accelerated process that ensures that there is a cure available in Africa as soon as it is available elsewhere. And HCAP has been able to have various accomplishments around technical areas, community engagement, and collaboration. In the technical areas, we've helped to define and test the HIV cure definition, working with the target product profile, and you saw some of this in Mike's slides. We've also worked with the group that has been working on the sickle cell disease target product profile, their secretariat, and offering them our support. With community, we've worked with them to ensure that we're able to have some insights on the feasibility, acceptability, as well as potential barriers, and facilitate facilitators to implementation of a cure agenda. We've worked with different advocates to develop literacy materials, partnered with AVAC, and we're really appreciative of the work that they've done with JoJo. Currently, we're working on what we're calling the Cure curriculum with others that are online, and then working to develop a cohort of Cure leaders that understand the lingo that may still sound quite foreign to most of us. I'll talk a little bit more about the collaboration in the next few slides that HCAP has done. But the other new initiative that I wanted to talk about was the HIV Cure Community and Research Advocacy Collaboration. This has different partners, and part of our thinking is that funding for HIV cure research should be prioritized alongside advocacy. So you cannot just fund us for advocacy or fund us for research, but fund for both. And I think it was on one of the earlier slides, I was quite dismayed to see that out of the millions and millions of dollars spent around HIV cure, less than 0.1% has been spent on advocacy. So clearly we have to do a lot more there. So with the cure collaboration, the partners that have come together, AVAC, HCAP that I work with, GGTI, Sante, African Alliance, and the International AIDS Society. So mostly, and on this slide, you see the different strengths that we bring as a consortium. So we're working together for greater impact. Our goal is essentially to have by 2027 a critical and diverse mass of African stakeholders. To have critical mass of African stakeholders that can own the cure agenda. And we're doing these through various outcomes. Essentially, our first outcome is to ensure that there is a structure that is able to bring these consortium members around a common vision and is able to set out a strategy that includes various initiatives and activities that can deliver and ensure that we meet our goal. Our first outcome is to build awareness and capacity in key potential leaders to take the cure agenda forward on the continent. And then moving on to building coalitions and networks that are really country-led and have programs of actions that are grounded from the country up. And then working towards our third and fourth outcome, which is ensuring that we have a realigned HIV agenda here on the continent that also talks about HIV cure in terms of country strategies and has continental research. And then initiate these communities of practice to share and learn and network on cure development. And finally, work towards having a really great Pan-African cure conversation. So we have 5 pillars that are working towards this goal. And these include improve and promote community engagement, build African leadership in HIV cure research, and then also build African leadership in HIV cure advocacy, and ensure we're able to facilitate regulations and policy environment, and most importantly, attract and retain young and early career investigators that are interested.
You may have seen that the timer has
gone off, yes.
Yeah.
I'm really finished now. This is the very last slide for us in terms of some of the success we've had over time, and we're still working on this. I'd like to end by, again, acknowledging the various groups that we've worked with in this last initiatives, and thanks to the Bill and Melinda Gates Foundation, as well as AIDS Funds for supporting the work in the last initiative that I talked about. Thank you so much.
So thank you, Susu, for this this overview. I thought it was actually very important that you pointed out that the amount of funding that we spent on advocacy efforts is actually less than 1%, actually far less than 1% than the total funding that we put in HIV cure research. So this is really something that, at least something that I would endorse, that we put more emphasis on that. It might be a nice bridge to the final panel discussion, for which we have about 15 minutes. And the way that we structured this is that we will address the questions that have been asked in the chat. We have a couple of questions here, but we love to see more. So if you have questions, put them in the chat, please. We now like to ask Dr. Carl Diefenbach and Devi Sengupa from Gilead to give a bit of reflections on what they just heard. Carl, you are the director of the Division of AIDS, and as such responsible for, I think, over $1 billion in HIV research funds. Shiva from AVEC pointed out how important your contribution is in the whole funding landscape for HIV cure research. So very much looking forward to how you see the future and what you think are the important hurdles that need to be solved.
Well, thank you for that monumental question. This has been a fantastic exercise in putting forward what is occurring in sub-Saharan Africa and elsewhere in HIV cure. The NIH is committed to supporting innovative research. And if we're going to engage in innovative research with people living with HIV, we have to go where community is. We have to engage community and continue to engage investigators and community in the questions that are of highest relevance. That's a very big picture level. The message today has been about engagement and equity, all areas that we fully support. I was really glad to see the inclusion of our extensive work in pediatric HIV cure research. Just a small example, P1115 has been completed. That, like many people have tried to replicate the Boston patients, the Timothy Ray Brown's experience, we've been focused with Deb Prasad and others on replicating the Mississippi child. And that trial has been completed. It was rigorous. It was the first of many papers has just been published, and their work has been presented at the Conference for Retroviruses and Opportunistic Infections. That said, all that work was done in sub-Saharan Africa. So we have had a presence. We focused on all aspects of cure, but something else that I want to make sure that we don't lose sight of is part of equity in this equation is making sure we maintain and grow access to the best antivirals for all. Because the individuals we're going to want to be able to engage in cure research and ultimately to receive curative therapies need to stay alive, need to keep their CD4 counts up, and need to continue to take the best antiretrovirals. So without getting into excessive details, these are wonderful programs. We are partners with so many of you, including the Gates Foundation, so we can keep moving forward on bringing cures to the people who need them most. That is clearly part of what equity and inclusiveness means for the Division of AIDS. So I'll stop there and then be happy to answer questions.
Thanks for those reflections, Carl. And thanks for bringing up the point of equity. And that's a very important element. We have quite a bit of funders, small philanthropic funders, larger philanthropic funders on board in this call, and I really would like to see, that the investments that hopefully they're going to make in this area translates into something that is accessible to everybody. And it might also be a nice bridge to Davy. Davy, welcome to the webinar. You're representing the industry today as the Director of Clinical Development at Gilead Sciences and responsible for the important work that you're doing on HIV cure. So can I ask you to give some reflections on what you have heard this morning?
Sure, and thank you so much for including me. It's a really important discussion, and I think I've enjoyed all the speakers' points today. So, and at Gilead, we really think that to achieve an HIV cure, it's going to take a lot of cross-sector collaboration and funding, as we've been talking about, and we're committed to this both through our own research and development programs, and then also in providing funding. And across both of those arenas, we have partners in academia, community, government, nonprofits, and other companies, and we work with several of the people who are here today, both I think in the audience and on the panel. So it's great to see everybody. So I'll just mention our Cure Grants program that we established in 2016. We've given almost $36 million since then to researchers around the world, and this cuts across both translational, preclinical, and sociobehavioral research. And I saw some comments in the chat from Corinne that social behavioral research is absolutely critical, and we couldn't agree more. So, and then also just to mention that we're proud that one of our recent grants was actually to the Santé Consortium that Zuzu and Thumbi both referenced, and we're hoping that that helps to train the next generation of African scientists, and we're also a funder for HCAP. And then I guess, one thing that I noticed that was a common theme throughout this webinar, it's kind of what are the two big areas of focus for HIV cure right now, and the things that I think I heard were about coming up with effective interventions that are also safe and affordable and accessible. And then number two, developing biomarkers so that we can figure out if those interventions actually worked. And ideally, those biomarkers could be reliable enough that we wouldn't have to put people through an analytical treatment interruption, or we could gate the analytical treatment interruption on a certain threshold of the biomarker. So we agree that those are kind of the two big areas that we need to focus on altogether. And while I outlined some of the things that we're doing in that space in terms of funding, I think we and other companies can always do more. So I think this is a really good way to kickstart the discussion, and we'd love some feedback on how to engage with other funders, potential grantees, and how can we all kind of coalesce around these priorities and amplify our impact. So I'll stop there, but thank you again for the opportunity to be part of this.
Thank you.
I was
And
on
thanks
mute.
for all of.
Yeah.
Go ahead, Remco.
Yeah. Well, thank you, David, for your contribution. Also, thank you for bringing up the point of analytical treatment interruptions. So I saw that there was a question in the chat, and I'm sure that the audience do have questions on that. So perhaps I can ask Thumbi to reflect on, the issue of analytical treatment interruptions and how you think that will evolve over time. Perhaps also a bit of the African perspective on that. On ATIs.
Yeah, thank you very much, Remco. I think it's perhaps I should start by saying that there are very limited analytical treatment interruption studies, obviously, that have been done in sub-Saharan Africa. We are doing one of those studies in the FRESH cohort in collaboration with Gilead and NIH and the Reagan Institute. I think in our experience, there have been quite a number of challenges around how to actually do it and do it safely. Obviously, we think that it is important to do it in order to answer the question of whether the intervention is actually working, because at the moment, there is no other way to tell whether an intervention for HIV cure works. So we are doing a very careful sort of intervention with regular monitoring of participants. But there are obviously issues around patient safety and protecting participants and sexual partners that come into play into this. So I do think that analytical treatment interruptions are really important and need to be done in order to answer scientific questions of whether cure interventions work. But they will need to be done in a very careful way. And I think we do need to develop a consensus. I am aware that there are some guidelines, international guidelines that are out there for how to do analytical treatment interruptions, but I do think that we need to update and regularly look at any new evidence that comes up to tell us whether this is safe and how best to do it. So that's what I can comment briefly about this issue at the moment.
Thank you so much. We're asking all of the speakers, panelists, to go ahead and come back onto camera. If you have questions, this is the time to please put them in the chat as we will go through those. One of the questions was whether the Mathilda Krim Fellowship support of new young investigators doing social and behavioral research related to HIV cure or whether it is supporting that, and if not, can they? Is that something somebody could answer?
Yeah, so this is Jeffrey Lawrence. So when the CRIM fellowships were first started, we had distributed several grants in the psychosocial areas and behavioral areas. We are now cure focused in terms of basic science cure focused, so that the CRIM fellowships that we fund, and they're 2-year fellowships renewable for a 3rd year, are to help establish young investigators in basic research labs to go on to get a full position, so that in order to apply for a fellowship and in order to be granted a fellowship, you need actually to have your university say that you're on a track that will permit you to get a faculty position. And they're incredibly competitive, but all of AMFAR's research at the moment is focused on cure. And cure in the kind of basic research area. We no longer are funding the behavioral and psychosocial issues of cure. Things may change. Actually, tomorrow we're having an all-day strategic planning meeting at the foundation to discuss pathways forward. But at the moment, the answer is no.
I'm looking at the clock, Mason. We're running quite closely to the hour. There were a couple of questions that I would say fall under the umbrella of social and behavioral research in this field. And maybe I can ask Monique Nijhuis to answer, the perspective on how important that type of research is and how that's integrated in the work that you do.
Yeah, thank you, Remco. I think coming back to the question also on ATI, I think that's a good example. If you are thinking about ATI and you're thinking about protection of the partner, that was one of the questions in the chat. I think it's really important to get insight in the social and behavioral context of that particular person, but also the particular cohort and the scenery. For instance, if you're thinking, as Tommy explained, about the young girls present in a fresh cohort, it may be a little bit more difficult than when you're thinking about MSM in Western Europe with maybe 1 or 2 partners who have this close to their environment, whereas for the fresh participants, they may not have, this close to their partners, and therefore it's also difficult to provide any partner protection. So I think, from many different fields, I think it's really important to engage with social and behavioral scientists to get a feel for, what is needed, what we should do in a different context, and also how we should move forward to a cure for all people, and what that cure should look like. So I think those are important things that we are trying to address also in our Spiral project in the coming 5 to 6 years. I think there we will see, how we can benefit also as biomedical researchers from their input. So that would be my answer to the
Thank
question.
you so much, Monique. We're at the hour. Mason is going to close the meeting in a minute. But before we do so, we have an important announcement from AIDS Funds that we'll do together with SIDAction. So I would like to invite my colleague Jennifer Pasquer, Scientific Director from SIDAction, to enlighten us on what is going to happen in 2024.
Exactly. Thank you so much, Remco. Hello, everyone. So as Remco said, I'm Jennifer Pasquier. I'm from SIDAction. SIDAction, for those who don't know it, it's like an ONG also that's funding research in France, research around HIV. And so we are pleased with Remco to announce that AIDS Fund and SIDAction are joining together to do call for proposal on HIV cure and remission for 2024, for the year 2024, with the aim to accelerate advance in HIV cure research. So the budget of this call of proposal will be 2 million euros, and it will be open to a researcher in France, in Netherlands, and in African countries. So we, maybe I can share, can I share my screen maybe quickly?
So we prepare like a landing page for this call of proposals so people can express their interest. So we'll send the email with the link for this landing page. I think Remco, you have the email of everyone and we can do so. And so the goal is that you can express your interest during December, January, and then we'll publish the definitive call text in February 2024. We'll ask for a letter of intent that have to be done by May 2024, and then we'll do the evaluation of the letter of intent in June, and then submission of full proposal in September, review and the announcement of the awarded project in December in 2024. And so the goal is to try to engage community researcher, academic researcher, and like in France, in Netherlands, and in African countries, and try to do like multidisciplinary project.
So Jennifer, thanks so much for that announcement. I saw a lot of applause during your talk, so I think people appreciate this, and we are also very excited to start working with you and make this possible. So Mason, for you, the official task to close the meeting. But before I do so, I would like to thank everybody from the panel for their contribution. I hope it was inspirational for the audience, and I trust it has been inspirational because we have touched on a lot of scientific funding and community engagement and advocacy challenges.
Yes.
So over to you, Mason.
Yeah, on behalf of Funders Concerned About AIDS and all of our members, lots of gratitude to the researchers, the funders, civil society advocates, both on the call, speaking, as well as those participate in the chat for all of your work. We can actually get to this single shot cure as well as actual supports that we need for everybody if we work together. So a lot of gratitude. We will be sharing this video, so keep an eye out for the recording. If you do have other questions for the speakers or ideas of other kind of next stage conversations you'd like to have, don't hesitate to reach out. And in the meantime, have a great rest of 2023, and we will be seeing you in the new year. Thanks, everybody.
Thank you all.
Thanks.